For tomorrow, if we get through this one today, I want to try and get through the next two PowerPoints tomorrow. Wednesday we may I want to try and get through maybe two on Wednesdays, just because we have a little bit more time on that day. Tuesdays I'll try to keep it to no more than half an hour, so whatever we get through in a half an hour. All right. Leukopoiesis and megakaryopoisis. We'll talk about hematopoiesis more in general a little bit later when we get into the red cells. But I want to start talking about basically the evolution and how these cells grow up. Okay, so we have two types of stem cells. There's the pluripotential. Okay, actually there's a third kind. There's the totipotential. That's your blastocele cell that can become anything. In other words, it has no idea what it wants to be when it grows up. Pluripotential means it can pretty much still go to any cell line, but it's starting to develop some characteristics. The progenitor stem cells, those have decided what they're going to be when they grow up, and they start to dedicate to a specific cell line. The more advanced they are, the more dedicated to that cell line they are. Our primary hematopoietic progenitor cells are the colony-forming unit, or CFU-L, which is our lymphocytes. They're sort of snobby. They're all by themselves. Everything else comes out of the GEM, G-E-M-M. The granulocytes, the erythrocytes, the monocytes, and the megakaryocytes. Megakaryocytes being our platelet precursors. Okay? Cytokines. I'm going to tell you right now, what do you need to know about cytokines? They exist. Okay? Any test questions on this are probably either going to be like, which cytokine is effective on granulocytes? G. Okay. I am not going to get real in detail as far as knowing the cytokines. If you get everything else down and want to start studying the cytokines, great. The ones that you need to know are erythropoietin and thrombopoietin. We'll talk about those very much in depth, okay? But what I want you to know about them is that they regulate hematopoiesis. They either inhibit or encourage development of these cells. It's a biofeedback mechanism that either inhibits or encourages the development of certain cell types. And that's pretty much what I want you to know about cytokines. There's a lot to know. It's massive amounts of information, but not where I think you should spend most of your time. Myelopoiesis simply means anything from the GEM that is coming up. And there are a bunch of cytokines right there. That's nice. We got lymphokines. That's nice. Some of these will come up, the interleukins will come up in serology. We'll deal with them when we hit there, okay? Megakaryopoisis. This one I want you to remember, okay? TPO, or thrombopoietin. And the main reason I want you to remember that is to remember that it is a platelet. It encourages platelet development. And the reason that's important is when we're treating our patients with chemo, it often suppresses the bone marrow. Well, we can't just give them a stimulant for the bone marrow, because frequently that's sort of counterproductive to the treatment we're giving. But they do use thrombopoietin so that if their platelets start to fall, they can just give them a synthetic form of this hormone and try to stimulate platelet production. The downsides to artificial thrombopoietin cost, I think each dose is something like $15,000 or $17,000 for a single treatment with this stuff. And the other downside is it doesn't always work. This stuff you need to know. Not only what traits we use for cell ID, but how they change as the cell matures. The general traits that we use are size. most of the time, and please keep in mind there are exceptions to every single rule, but most of the time, cells start out larger and they shrink as time goes along. So our blast is probably going to be our biggest cell in most cases. Color-wise, and we have to differentiate the cytoplasm and the nucleus. The cytoplasm is going to be a much darker blue in our younger cells because there's a lot more RNA production and a lot more RNA activity. And the blue color within the cytoplasm is proportional to the amount of RNA that's there. Once we hit a seg, there's a very, very little RNA production, very, very little protein transcription going on, okay? The granules will start to appear when we're talking a granulocyte, obviously. If we have an agranulocyte, we're not going to see granules in it, right? The nuclear chromatin pattern, and we've talked about this a little bit more, as we go through more and more cells, it'll start to become more and more visible. The chromatin pattern becomes more dense and clumpy, with definite areas of parachromatin visible. That means that you can see it'll start to strand up, it'll start to clump together, and there'll be areas in between it. Okay? It is probably the hardest thing. Once you finally get it, it's one of those things, I don't get it, I don't get it, I don't get it, and suddenly you go, ah, that's what she's talking about. I just would like to get to that ah moment somewhere before the end of the semester. Okay? And we'll look at some stuff side by side, like a blast versus a seg. It's pretty evident there. NC ratio, as the cell matures, the nucleus is going to take up less and less of the cell. Okay? The function of our mature white cells, our mature leukocytes especially, are really not dependent on the nucleus. That's why the seg pretty much shrivels up and kind of becomes nothing. Okay? Once the granules have been created, that is the functional portion of the cell. So it's no longer requiring to make proteins, which means the RNA goes away, the nucleus shrinks out because we don't need the nucleus to direct protein development. So as the cell matures, for the most part, the NC ratio is going to decrease. There will be less nucleus, more cytoplasm. Okay, there are obvious exceptions, the lymphocyte, right? And the shape, well, obviously we have to look at the shape to see what, and what's the shape going to do as it matures? Well, it depends on which cell we're looking at, right? We're going to start with lymphocyte maturation. This is pretty much the easiest one, fairly straightforward. Our earliest cell that we can identify as lymphocytic in origin is a lymphoblast. It originates in the bone marrow and in the lymphoid tissue. So this one's a little bit different. Most of our hematopoiesis, leukopoiesis, occurs only in the bone marrow. The lymphocytes can actually mature elsewhere. We will talk a little bit about that this semester. We will talk a lot about that in the fall. They tend to be between 10 and 18 micrometers in size. Now, what does that mean? Well, each red cell is between 4 and 6, so it should be about, 3 to 4 times the size of a red cell. Okay? So you put 3 or 4 red cells in there. It's going to have a round or oval nucleus. Frequently it will have nucleoli. And what is a nucleoli? See these little kind of holes in here? Okay. And again, as we go along, we're going to look a lot more detailed slides and a lot better pictures. Here's a nucleoli right here and right here. It's like a little circle within. It's an organelle within the nucleus. Okay. These right here are pretty easy, pretty good, easy to see nucleoli. Don't worry, we'll go over cell review. Those will become much more clear. Okay. Scant cytoplasm. There's not a whole lot of cytoplasm in a lymphoblast. And truthfully, telling the difference between a lymphoblast and a myeloblast, we just call them blasts and let the pathologists and cell identification that we'll talk about tomorrow do it. Okay. For the most part, we just call it a blast and move on. The prolymphocyte, it's going to be smaller than a blast, may or may not have nucleoli in it. You're going to start seeing a denser chromatin pattern. And do we see prolymphocytes? Almost never. I have one slide with prolymphocytes on it, and that's because the guy had prolymphocytic lymphoma. So they're just not something we're going to see very often. Or if we see them, we don't recognize them 99% of the time. And that's experienced types. A mature lymphocyte is small, 9 to 15 micrometers. Basically, the nucleus of a lymphocyte should be about the same size of a red cell. But what did I tell you lymphocytes can look like? Anything they want. Lymphocytes are just pain in the butt. They can do anything they want. Okay? But a normal, mature lymphocyte in a non-infected person is usually going to be just like this. It's going to have a very dense nucleus, very little, almost non-existent cytoplasm. It's going to be about the same size as a red cell. Okay? That is a prototypical, normal lymphocyte. And it would be lovely if everybody had them, but they don't. A plasma cell is actually an abnormal cell. We don't call them in peripheral blood. We only call them in the bone marrow. It is a B cell lymphocyte. Again, we'll talk more about those when we start getting into our leukemias. It is a B cell lymphocyte that is producing antibodies. That's what B cells do. We will have what they call a blocked chromatin, where if you look at the chromatin pattern here, this is all just kind of homogeneous, but it's very dark. Here, if you notice, there's big dark blobs in there, and some areas that are a little bit less blobby. I know technical terms here. We're going to have a clear to dark blue cytoplasm. The defining characteristics of a plasma cell, however, are that windswept appearance. It looks like somebody's, over on one side with a fan blowing all the cytoplasm so it's streaming out behind it. Okay? The other thing that is very characteristic, if you can see it from the angle you're looking at when you're staining it, is this what we call perinuclear, or next to the nucleus clearing. Okay? That is where we've got antibody production going on. Monocyte maturation. And this slide's really good because it shows you, okay, you see the chromatin here, how dark and dense that is? You see how fine and lacy it is here? Much different in the chromatin pattern. Okay? These have definitive nucleoli. This is probably the best one. You see this little circle-like area in there? Anytime you see those, you want to slow down on your differential and look real close. Okay? Can ATLs have those? Of course. Okay? But for the most part, if you start seeing nucleoli, you really want to slow down, take your time on the diff, and make sure you don't have blasts. Or call somebody over. We frequently do blasts by vote. I don't know what this is. Somebody! The monoblast is large. Okay? You can't really differentiate it from a myeloblast. Why? Well, because the blast is the next step after the GEMM, after that GEM CFU, colony forming unit. So really, your myeloblast and your monoblast are pretty much the same. Okay? A very, very experienced pathologist can tell the difference. Frankly, once again, we generally use other testing to help us really identify it. Morphologically, or just by its shape and size, what we're hoping for is don't miss blasts. Don't call blasts monocytes. Life goes on. Okay? The basic competency for differentials is being able to tell me what's abnormal. Even if you can't identify it, as long as you recognize what's abnormal, you're not going to kill anybody. And that's kind of our hope, is that you don't get out of here and kill somebody. So, minimum competency, you have to recognize that it's abnormal. Okay? You can then get out your atlas, go online, call a more experienced tech over, call me up at home. I get those phone calls all the time. What am I supposed to do, people? I can't see it. So, a promonocyte, I wouldn't know a promonocyte if it bit me in the nose. Okay? It's more mature than a monoblast and not as mature as a monocyte. Okay? Am I going to have a promonocyte on a test for you all to look at? No, because if I can't recognize it, you certainly aren't going to be tested on it. Okay? And on tests, blast. That's all you have to tell me. You do not have to differentiate them. Blast. Okay. Monocyte, great morphological variation. The nucleus tends to be a little more indented, lobulated, or folded. I am going to deny with my last breath if anybody says I had ever said this, but if I'm in doubt and I really can't tell if it's a lymph or a mono, if it's round, I call it a lymph. Is that a good way to do it? No. But you gotta have something. Okay. But I will deny that I gave you the round lymph. I didn't say that. Nope, not me. Can you have monocytes with a completely round nucleus? How do you tell them from a lymph? Flip a coin. No, what you do is you look at the chromatin pattern and compare it to the other cells on the slide. That's very, very important. Find a nice typical lymph, if you can, on the slide. And does this cell look the same as all of the other ones? Then it's probably a lymph. If it looks significantly different, it's a mono. Okay, so sometimes it's a matter of company it keeps. What else is on the slide? Sorry? Monocytes are usually larger than lymphs. However, atypical or reactive lymphs can swell to 2 to 3 times the size of a monocyte. Monocytes are generally in the peripheral blood just along for the ride. They're not generally active. They can be, but for the most part, they are not. Few necrobiotic or fascia necrotizing diseases will give you an increased mono count in your peripheral blood, but for the most part, they're just headed where they need to be, and that is in the tissues. In the tissues, they swell huge. Okay, this is a normal size seg. Look at the size of these macrophages. In fact, as you look here, you can see this one actually ate a red cell. So we would call it a erythrophage. Okay, this one here, it really went to town. We've got a red cell and 2 white cells. I don't know what we'd call it. I guess a leukophage, a leukoerythrophage. Okay, call it hungry. But the biggest piece is when they get into the body fluids, their job is to eat all the garbage collectors. Okay, they're going to swell in size, and they are almost always going to have vacuoles and this real kind of foamy cytoplasm. That's where they've been eating stuff. Those are ingestion vacuoles. So when you're doing body fluids with Jean this fall, that's going to be one of your prime criteria for how to tell it's a macrophage, is that foamy cytoplasm. It's going to have vacuoles. Okay? And that'll help us differentiate it from mesothelials, which we aren't going to talk about yet. That's our agranulocyte maturation. Those are pretty simple. Blast, pro, mature. They have 3 stages. Life is simple, easy. That's it. Okay? Granulocyte maturation's a little bit more complicated. And this is going to be all of the granulocytes. And which cells are granulocytes? The Phils. The Phil family. I can never think about it without hearing the announcer on the Family Feud. You know, this is the Phil family. We start out with a myeloblast, we go to a pro, but then we split out farther. We go to a myelocyte, a metamyelocyte, a band, and then we get to a mature cell. So we actually have 1, 2, 3, 4, 5, 6 distinct stages in this maturation. Hint, I almost always on the test say, what is this? List the maturation sequence of the granulocytes, and it's a fill in the blank. So You might want to know this. The myeloblast. Okay? These are party. These are very party blasts. Okay? Can you see the fine chromatin pattern? Is it starting to make sense to you? When we look at a seg, it's all clumpy and dark. When we look at a lymph, it's all clumpy and dark. In this, it's fine. It's sandy. Okay? It's not real dense. We have definitive nucleoli. Okay, you can see these little sort of, they're not really holes. They're just round areas within the blast. Okay? Our NC ratio is very, very high. Lots of nucleus, very little cytoplasm. Our cytoplasm tends to be a little darker blue. I've even seen it a lot darker than this. This is actually from a patient with acute leukemia. Okay, so this is a peripheral blood. Blasts are never normal in the peripheral blood. Never. Yes, sorry. It's okay.
These are eosinophils, basophils.
Okay. Yes, this is all of them. That's the myeloblast. They won't differentiate out until a later stage. Okay. So for right now, I can't tell you if these are going to grow up to be neutrophils or eosinophils. It's a very good question. But yes, this is all three of the granulocytes start out as a myeloblast. They, the cytoplasm is basophilic, in other words, it's blue. There are no granules in this stage. The blast does not have granules. A granulocytic blast has no granules. Okay, got that question? Got that one. All right. The promyelocyte, and what's really funny is we see less of these than we see blasts. You would think that as it matures you'd see more of them. Honestly, when we're doing diffs, we see blasts much more frequently than we see pros. They're just not that common to see. They may be slightly larger than a blast. They may be smaller. Again, these are not normal in the peripheral blood. The nucleus is going to be very similar to a blast. It's going to have a very fine chromatin. It may still have nucleoli, okay, but they're not going to be as prominent. They're not going to be as easy to see. How do I tell the difference between a myeloblast and a promyelocyte? These dark purple granules, or in this case, blue granules, okay? The promyelocyte has primary granules. They're azurophilic. They're either purple or they are dark blue. Some lymphocytes can have these azurophilic granules, but it's going to have maybe a dozen, 15, 20 at the most. In the promyelocyte, they're going to be all over the cell. There's not going to be just one or two here and there. They are going to be distributed through the cell. The granules contain myeloperoxidase, acid phosphatase, and esterase enzymes. That's not nice. I won't ever ask you that. The reason I used to teach that is because we used to, differentiate them using that stuff. We have better ways. The myelocyte. This is very important. This is where we start to decide what we're going to be when we grow up exactly. Myelocytes are the first stage that I can differentiate eosinophils, basophils, and neutrophils. And the way I'm going to do that is we're going to start seeing the secondary granules. So in what color are the secondary granules going to be in a neutrophil? Pink. What about an eosinophil? What color are the secondary granules going to be?
Orange. Pink or orange.
Orange, very orange. Okay. What about in a basophil?
Blue.
Blue. Basophilic myelocytes, if you see those anywhere but the bone marrow, start praying because it's not a good sign. Okay. I do not have a picture of one, and I doubt you will ever see one. Unless you're doing bone marrows. Okay. The nucleus is going to be eccentric. What does eccentric mean? What is it? No.
Obvious.
That's eccentric off center. Okay, it's going to usually tends to slide off to one side. It's going to start to elongate. It's going to stop being quite so round and start to get more oval shaped. And one side will start to flatten out. The metamyelocyte tends to be a little bit smaller than the myelocyte. At least that's what the book says. The key with the metamyelocyte is that side that had started to flatten out on our myelocyte is going to start to indent. Okay? So it gives us what they call a kidney bean shaped nucleus. It has a denser chromatin, especially along the nuclear membrane around the outside of it. You're going to start to see the chromatin start to clump up. The nucleus has become obsolete. It's not doing as much. In the promyelocyte and the myelocyte, it's still making those granules. It's still creating proteins. It still has some RNA stuff going on. By the time you hit the metamyelocyte, the nucleus is really becoming obsolete, and it's just kind of shrinking down and getting out of the way. The cytoplasm may be faintly pink, almost no blue background, which of course belies right here. The neutrophilic granules are going to predominate. We should see less than 1% of these in the peripheral blood. You should never have more than 2% immature grands, which is going to include myelocytes and metamyelocytes. How do I tell the difference between a myelocyte and a metamyelocyte? The indent. If it's indented, it's a meta. And believe me, we are going to review these until you're ready to throw things at me, which I know you already are, but that's okay. The band is going to be smaller than the meta. The nucleus is going to be U-shaped or deeply indented. The opposite sides or lobes are roughly equal size in diameter, for the most part, usually. The nuclear indentation is going to be less than half. Okay, this is incorrect. This is incorrect. It is greater than half of the nucleus. Because what you're going to do is you're going to use your imagination. You're going to turn this into a circle and you're going to bisect it. If this dent goes more than halfway, it's a band. If the dent goes less than halfway, it's a meta.
It says greater.
Oh, it does say greater. Sorry, I looked at it wrong. Okay. The mature, we've already talked about. You're going to see the segmented nucleus, pink granules in the neutrophil, red in the eosinophil, and blue or black in the basophil. Yeah, we got one last slide. We can get through this. Megakaryopoisis is a little bit weird. Actually, it's a lot weird. Because what happens with this thing is it meioses, but it doesn't mitoses. What happens, the nucleus, when a cell divides, the nucleus replicates itself, right? And then it divides, and then it splits the cytoplasm between the two cells, right? Well, in the platelet precursors, the megakaryocytes, what happens is the nucleus splits, but it never shares the cytoplasm. It just all stays in the same cytoplasm. So what you wind up with is this cell that has multiple nuclei in it. Usually they stay connected together, and this massive, huge amount of cytoplasm. Because what the platelets are, if you look real closely, the platelets basically are shredded cytoplasm. The nuclear membrane, the outside of the cytoplasm, basically gets torn up into little bitty pieces, and that is what the platelets are. Okay, with all the granules and everything that go with them. The promegakaryoblast, yeah, I ain't never seen one of those. And you're never going to see the, if you see this in the peripheral blood, you don't have peripheral blood. Something's wrong. The only place you are going to see these is the bone marrow. These do not go in the peripheral blood. They're too big. They can't squeeze out of the capillaries. Okay? When we see platelets, you notice the bottom ones are nice and normal. The larger they are, the more immature they are. And the way I remember that is if you think about if you're tearing up confetti, it's the beginning of the evening and you're sitting in there and you're tearing it into nice little teeny tiny pieces and you're being all exact. By the end of the night, when people are stealing your confetti and you're trying to make more rapidly, what do? You start tear off big old honking pieces, right? You're not gonna sit there and tear it into little tiny shreds. You're just gonna pull off anything you can and fling it out there. Okay? So, if you have an increased platelet use to where you have to step up your platelet production to keep up, you're going to get this, the cells aren't going to divide it down into those, it's not going to get shredded off into those nice tiny little platelets. It's just going to grab off hunks and fling them out there. Here, see if this will work. Okay? So immature platelets are bigger and bigger. And I actually have one patient who has platelets that are almost twice the size of her white cells. She has a 2 million platelet count. Okay? Where, what, 200,000 to 400,000 is normal. She has a 2 million platelet count. All right. We will be going over these cell types. We will be looking at those cell types. Probably Thursday, I'd like to do some cell review. Okay? To where we just, I'm going to put them up. We're going to go over one at a time. And we're going to talk about it. Okay? So we will go over those before the test on Tuesday when we will start seeing them. Quick question, do you want to continue the cell test with the main test, or would you rather have it by itself? Raise your hand if you want it with the main test. Okay. Raise your hand if you want it separate. And raise your hand if you don't care. Okay, we got a lot of don't care.
Do what you do.
I think we have more separates and don't cares. So I think we will separate it. Do you want to have it on Wednesday or Thursday? If we have it on Thursday, we can do cell review on Wednesday. Does that make sense? Then we can do cell review. I can tell you exactly which, we'll go over the ones that are on the next day's test. Keep in mind, anything that was on this week's test is eligible for next week's test. Anything that's on the first 2 weeks is eligible for the third week. Anything that's on the first 6 weeks is eligible for week 7. So we're going to build this as we go along. Okay? When y'all are frustrated and I throw a seg on there, okay, today, there couldn't be 2 segs on there. Yes, there could. Week 6, there couldn't be a seg on there. Yes, there could. And be nice. Okay, so yes, any cell that we've had in the past is eligible for the next week's cell. But what we'll do then is cell review on Wednesday. We'll make that part of lecture because I told you I have a little more lecture time. And then Thursday we will do, the first thing you come in, there will be a cell test. And it'll just be that one sheet, somewhere between 10 and 15 questions usually. Identify the cells, turn them in. Spelling, try and get close, guys. Okay, if you are off a letter or two, I'm not gonna totally throw it out, but it's gotta be reasonable. Okay. Somebody last said, well, I just forgot 4 letters. It was supposed to be a myelocyte, or it was supposed to be a metamyelocyte, and they put myelocyte. No, I don't believe you just misspelled it and missed the first 4 letters. Okay. All right, we're gonna do white counts. Did anybody